Thank you, Dr. Manoria, for your kind words. Thank you for arranging these CMEs to keep us updated. Dr. Rajeev Agrawala is very much associated with our Lipid Association of India, and today he is going to talk on a very important topic: regression of atherosclerosis, whether myth or mission. Our college days we were taught that atherosclerosis is never reversible. What a plaque has occurred. But now with lifestyle, drug therapy, statins, PCSK, there is a lot of evidence that can be regressed. So Dr. Agrawal will throw lights on these issues. May I invite Dr. Agrawal, please?
Good morning, and thank you, Dr. Manoria, for creating this wonderful program on Sunday morning. Obsessed about and a futuristic way of looking at it. I think my story is very old, and maybe 10,000 years before Lord Krishna was born. As far as I understand, Lord Krishna was born 5,000 years ago. So this is a very old story, and we have to have a new look at this story. This is a slide I created for this moment. We know atherosclerosis can manifest as chronic coronary syndrome, acute coronary syndrome. We understand residual risk modification, host factor, they all interplay. And the syndrome keeps on moving from one point to another point. Majority of us are in this maze and feel this is the reality of life. But ladies and gentlemen, there is a way out. There is an exit route also, which we have to talk and understand and practice, that there is a concept and reality of eliminating atherosclerosis. That is what I am going to do in next 15 minutes or so. The concept is very valid. This is 2024 ESC, Patrick Saraius, who is hardcore intervention cardiologist, and his futuristic vision for 2040 is pharmacological revascularization. The mechanical revascularization may diminish at least in the years to come. So that said the preamble of my talk, that even intervention cardiologists believe that there is a space or future in pharmacological revascularization. But the challenges are enormous. This is Dr. Crabb, who submitted his paper on Crabb's cycle to Nature, and it was rejected, 1937. So the problem is, when you are ahead of time, many people discard this hypothesis, this reality, this opportunity. And that is what is related to my problem. There is a vision, but less of understanding among the community that this is the way forward. We all know, whatever way we look at LDL cholesterol, it is attributed to atherosclerosis. CTD collaborators' meta-analysis showed us that whatever way you look at it, the lipid lowering, especially LDL-C lowering, bring heavy dividends. Dr. Braunwald talked about race to the bottom, and he talked about submolar LDL cholesterol, which is less than even 10. Let me introduce you to the grammar of atherosclerosis. There is a clinical way to understand the plaque burden. We simply multiply age into LDL-C and say the total plaque burden is milligram years. The risk of plaque rupture increases exponentially above 5,000 milligram years. That is a clinical way of looking at the plaque burden. But this is less accurate. What is more accurate is to do it on CT-CA, that today we can understand, calculate by newer AI-based algorithm, total atherosclerotic plaque burden and clinical outcome. Higher the plaque burden, poorer is the outcome. So now we are quantifying the atherosclerotic burden in coronary tree rather than talking of focal percentage stenosis, which is a mountain of disease. Today we are calculating the totality of disease. And the important slide is that 1% reduction in 1% reduction in plaque burden result in roughly 20% reduction in MACE. So there is another way of looking at atherosclerosis and MACE if we calculate the total plaque burden. The another way to look as far as the grammar is concerned, thin cap fibroathyroma, whatever situation we are, they are more prone for plaque rupture. So another grammar is thin cap fibroathyroma. Then another thing is a lipid-rich plaque is more prone for plaque rupture. And that is why there are three things you have understood. One is lipid core, a lipid core, another is total atherosclerotic plaque burden, and thin cap fibroathyroma. What are the vowels of atherosclerosis? Fibrous cap, thickness, calcification, atheroma volume, and new thing is neovascularization of plaque, which is again a determinant of plaque rupture. And we often feel anything outside the vessel will conceptually be useless. No. Perivascular fat is very, very important component in precipitating the acute coronary event, and there is a constant interplay, neurohumoral constant interplay between perivascular fat and coronary vasculature and endothelium. So these are 5 vowels of atherosclerosis. I don't have the opportunity to talk about the superiority of one modality over another, but these are different modalities by which you can see atherosclerosis. Different trials have used different methods. We will not be focusing on which trial used which method. What we will focusing that how they deciphered the reduction in atherosclerosis. Let us understand the evolution, how we have reached to this concept of regression. The primitive time, the earliest is AACO Milano study, which used reconstituted HDL, was given 5 weekly IV infusions, high dose and low dose. What was shown that high dose AACO Milano in acute coronary syndrome retards the progression of atherosclerosis. It does not cause regression. This is at 25 weeks, high dose at 25 weeks. Then we were really encouraged, and Stephen Nicol did it, a Milano pilot study, and this infusion was given on top of statin therapy. Then it was found that AACO Milano reconstituted HDL is not helpful. So everything was gone waste, and there was no longer any interest in this kind of modality. Then comes the Bronze Age, the statin era. We had a reversal trial, which was an atherosclerosis high dose with pravastatin, 18 months. The regression was not much on atorvastatin 80 milligram, but progression was there on this pravastatin 2.7. But when you see comparison, there is regression because relative increase in progression. In reversal, there was the percentage change was 34%, 46%, and the baseline we achieved LDL cholesterol was 80. From 150 to 80 is still very high, but those days 80 milligram was less than 100 milligram, and it was considered very aggressive LDL lowering. Then came the asteroid, which was 40 milligram, and what they did was percentage change was 53%, and LDL achieved was 60%, 60 milligram percent, the way you look at 80 in the other reversal trial. Another thing which was talked too much those days was 14% increase in HDL. And again, we showed that once you give high dose rosuvastatin, pulse atheroma volume of entire vessel, atherovolume in the most diseased segment, total atheroma volume, there was a significant reduction. There was another trial called Saturn, which compared head-on the two, but there was no significant difference between the two in terms of regression of atherosclerosis. So what mattered was that it is the aggressive lipid lowering rather than agent specificity which determines the regression of atherosclerosis. And regression of atherosclerosis is not statin-based alone. If you combine with ezetimibe, there is more regression. Once again, a unifying hypothesis that what matters is LDL reduction, not the agent specific. As I told you, one of the vowels is thick cap fibrotherma, which is stable. You see that fibrous cap thickness increase, lipid arch increase, making the plaque more stable. I showed you one of the vowels is a perivascular fat. The reducing epicardial fat was a possibility with statin, and it showed that statin has got extravascular effects on adipose tissue or perivascular fat. So once we summarize, we find that with aggressive lipid lowering, the calcium volume increases and pulse atheroma volume decreases, justifying, like in your Boyd days of pathology, there is calcification of tubercular atheroma. Similarly, when you do aggressive statin therapy, there is entombing of atheroma, which makes it stable. It should not be confused with coronary artery calcium, which is a pathognomic of disease. So this is a summary. Aggressive you are, better you are. The mean change in percentage atheroma volume. This is the same expression, and you can find out when you are at 50, 55, there is hardly any regression. And that is where my problem starts, because guidelines are still stuck up at 55 in international arena. There comes the iron age. You find Glagov trial, which is PCSK9, relatively chronic stable patient. And what they found that statin evolocumab percentage atheroma volume decreased, total atheroma volume is decreased, which is statistically significant. But my interest is here. If you give this combination to people who are less than 70 milligram, 81% of such people will show regression. And that is the opportunity. That is the message you have to carry home, that at 70, when you reduce it to ultra low level, there is an opportunity for regression of atherosclerosis. So it showed that real regression start at 50. And most of the guidelines, they stop at 50. Then came the hygiene study, which is more on acute coronary syndrome, evolocumab monthly. It showed baseline and follow-up LDL dropped to 28. And it showed that there is increase in fibrous thickness, there is decrease in macrophage index on evolocumab group, and the plaque becomes less of lipid core, more of thickened fibrous cap. There is more of calcification, and there is less of vascular, perivascular activity. So the plaque becomes entirely different when you treat with aggressive lipid lowering. If you look at Glagovan, Huygens showed better advantage because the plaques were more biologically active as they were amenable to regression. Pacman AMI, again, a beautiful trial used with different PCSK9, and it showed that there is change in maximum lipid core burden index at a point where the vessel was 4 millimeter, and aliricumab, which was the ODC agent, which was used in ODC, showed an aggressive reduction in lipid core. This is the summary. Primary endpoint, powered secondary endpoint, powered secondary endpoint in fibrous cap thickness. You find that every parameter is favorably effective with aliricumab. Same thing in a graphic form. What is interesting to note is that after ODC and Fourier trial, probably the ODC worker realized that their concept of maintaining a 50 in ODC is probably not relevant. So in this Pacman AMI, they went the Fourier way and achieved the LDL of 24. So that is what you have to understand, that unlike ODC, where the LDL, mean LDL at treatment was 50, it is 24 in this group, and you show how the lipid core disappears. That is the beauty of aggressive lipid lowering. So even in acute coronary syndrome, if you are aggressive, you modify the plaque acutely, which is a contrary concept to the conventional thinking. And there is an editorial, early catches the worm. The same study was presented with aliricumab called Architect study, which was in familial hypercholesteremia. What it showed that in young individual, if you give aliricumab, 91% of patients will show, 87%, roughly 90% of patients will show plaque regression. So earlier you work, more is the plaque which is young, it is amenable to regression. Later you work, regression is less because the plaque is more calcified. So ladies and gentlemen, you have not to work aggressively, but you have to work very early, because this study was very promising that 88% of the patients showed regression in plaque. So if we use PCSK9 on high-intensity statin, 2% plaque burden regression, 5% plaque burden regression at lesion level, 10% plaque burden regression at most narrow vessel spot. All these things, regression of atherosclerosis. So this is the way forward. As you decrease LDL up to 20, the fibrous cap thickness increases, and this increase in thickness not only makes plaque stable, but overall atheroma volume by reduction in lipid core burden index become very, very stable. Relative comparison of plaque, the fibrous cap thickness 42, 62 micron, and both the trials show that they were better off. Change in plaque lipid content, again you find that aliricumab is not a head-to-head comparison. You may say aliricumab is better. I'm not saying that. Similarly, there is a change in plaque macrophage content because we realize inflammation within the plaque is equally important. So these agents, when you regress atherosclerosis, these agents are also cooling the plaque. So vulnerable plaque to stable plaque, larger plaque to smaller plaque. These plaques are cool plaques now because the macrophage content is reduced. And you find that this goes on down to 0.5. 0.5 means up to 20, and this is further lower down. So ladies and gentlemen, when we talk of LDL level of 55, probably that is too far off from our realistic goal of reduction in atherosclerosis. There are newer agents which will help us in reducing those LDL. This is a Ladodalcibab, which is again a new drug which is causing reduction. So there is an upcoming storm of newer agents which will be hitting the market in LDL-C reduction. LDL-C level up to 10 milligram is shown to be safe, effective, and productive. Side effect profile, this is 4-year OLO. The OLE open label extension, there is no difference in side effect profile. This is magenta color is 0.5, that means 20. You find that magenta color on extreme left, there is no difference. Even cataract, cancer, hemorrhage, everything is same. Another agent is EPA, the evaporate study. Again, you find that placebo is red, EPA is blue, the plaque is favorably affected by EPA. Again, this is the intravascular study. And you find that there is a gain on every level. This is unlike CTT, we are talking of plaque, that there is gain in every parameter, every way you look at it. And there was a conclusion that this is the first elegant marriage of clinical trial results, reduce it, and imaging, because what we achieved in reduce it is being reflected in evaporate. Neovascularization is also reduced because neovascularization is a manifestation of atherosclerosis. This is one Chinese study which showed vascularization if you use rosuvastatin and atorvastatin vis-a-vis evolocumab. SGL plaque progression. Even colchicine is known to make the plaque stable. Mineralocorticoid receptor antagonist prevents aortic plaque progression. So there is a newer insight, newer enthusiasm to look at things which can reduce plaque, and lipid modification is probably the foundation at the moment. How I synthesize all this, I find that the plaque regression depends upon LDL achieved. We are not talking of plaque stabilization from where the story started about 30 years back. We are talking of plaque regression. And you see, Glagov, that there is a plaque regression, a possibility. Calcified plaques are more resistant. So you have to hit early. Younger patient, 25, have an opportunity to regress atherosclerosis, like we start talking of reversal of diabetes. Similarly, there is a possibility and realistic hope of regressing atherosclerosis. The coronary plaque regression and risk of adverse correlated cardiovascular events, they correlate as there is mean change in pulse atherosclerosis, there is reduction in MACE. So unifying hypothesis is that the moment we demonstrate a CT-based or any modality, imaging modality-based regression is plaque atheroma volume, total pulse plaque atheroma volume, there is reduction in events. I often believe in LDL reduction to LDL reduction. That is a new paradigm to my mind. And last thing which I want to synthesize is the arithmetic of atherosclerosis. Dr. Brown and Goldstein in 1885, in their Nobel laureate speech, talked of LDL plasma level of 25. And probably it took us almost more than 3 decades to understand that this is a reality. We are still fighting from 100. Americans are still holding on 70, Europeans coming to 50, and Lipid Association coming to 30. So there is a wide range. And often when we understand the uniformity, we find that why this change? Because there is a conceptual problem. If you are thinking of plaque pacification, plaque stabilization, any of these values will be good. But if you are talking of plaque therapy, then probably ultra low level of LDL, something like 25, 30, 10 will be the aim, and all these therapies are needed. So ladies and gentlemen, I am very emotionally charged person on lipids. I feel the name of lipid lowering therapy should be changed to plaque therapy so that the clinician understand they are hitting the plaque, because lipid lowering therapy does not connect them to plaque. I strongly advocate and call upon the policymakers, the guideline writers, no longer use the word as lipid lowering therapy. It started with the statins, lipid lowering therapy. I feel the exact nomenclature is plaque therapy. Whatever way you reduce LDL, it means the same. There is no specificity about agent. If you achieve a LDL of 20 with bempedoic acid and ezetimibe and statin, you are as good as any other thing. So there is no difference between inclisiran, in aliricumab, and this triple combo. What matters is the quantitative reduction. In lipids, there is no qualitative difference like we see in diabetes, where agent specificity is equally important. I'm proud of it that I'm part of Lipid Association of India, and probably we are the guidelines or the consensus document which is still lowest and talk about 30 milligram in high risk patient. To my mind, every patient who is young expressing atherosclerosis is mandated to be reduced to ultra low level of LDL, because our aim is to regress atherosclerosis. How to live 100 years before developing situation. Can we cure atherosclerosis? I think we can cure atherosclerosis. Our chairman of the CME, Dr. Manoria, has written a very good article recently, how to postpone MI to 100 years, and talking about the same spirit that we have to be very, very aggressive. When I talk all this, please don't take me otherwise. Never forget the lifestyle changes. There are nine crucial factors, and you have to build your drug therapy on top of it. A healthy lifestyle results in positive influences, and you can increase your age with health. So there is quantitative and qualitative increase in health. I summarize all of this by saying that regression is a reality and a visual phenomenon now. You have not to aim in younger patients less than 50 years of age, something like 50 or 70, you have to go for ultra low level LDL, because your aim is to get out of atherosclerosis maze and aim for regression of atherosclerosis. And this is possible now by imaging. Maybe in times to come, we have trials rather than a long-term trial, because we have correlated total atheroma volume with MACE, that we demonstrate there is a reduction in atheroma. Probably we don't need long-term trial of outcome. The only problem is if you don't expose an individual to long-term, safety profile will not be known. And the last thing, I am very categorical and optimistic that the industry will be open to withdraw rosuvastatin 5 milligram, rosuvastatin 10 milligram, atorvastatin 10 milligram, atorvastatin 20 milligram, because these are pseudo drugs because of their dosage. Clinicians, endocrinologists, even intervention cardiologists are using these drugs and giving false satisfaction to themselves and to the community that they are on lipid modification, while we understand these drugs are just more than placebo in the context of emerging concept. So I call upon the industry to voluntarily withdraw drugs like rosuvastatin 5 milligram, rosuvastatin 10 milligram, atorvastatin 10 milligram, atorvastatin 20 milligram, because they are not going to do any good except creating a false hope, and the clinicians are harming the community by not chasing the atherosclerosis. There is a Japanese saying, and I believe in it. I always say, as this say, read that again and again. If you get on the wrong train, get off at the nearest station. The longer it takes you to get off, the more expensive the return trip will be. So ladies and gentlemen, longer you take to understand this concept, more harm you will do the community and more expensive it will be to the community. Aim for ultra low level of LDL so that we regress atherosclerosis. Chase for ultra low level of LDL. And I'll summarize that we are not artery cleaners. We are artery healers. So you have to heal the artery, and healing means regression of atherosclerosis. Thank you very much.
Dr. Rajeev, you have given very clear-cut message. Hit early, hits hard. Get rid of atherosclerosis by eradicating LDL. What is the lowest level you expect from our patients in clinical practice, in primary prevention and in secondary prevention?
Primary prevention is a difficult ball game. The lowest level of primary prevention is in Jupiter, which is 55. But if you look at the data today, we have data up to 10 milligram, double-digit data up to 10 milligram in Fourier, where there is a risk in reduction in events. There is no mortality reduction in Fourier, but I believe this hypothesis is not tested in long-term trials. But if my patient achieves 10-20, I keep holding my drugs. There is no concept of reducing the lipid-lowering drugs, because if your patient is hyper-responder, then these patients are likely to show more of regression. So guideline-based up to 30, but if my patient achieves 10, 15, 20, I really enjoy it.
There is a lot of phobia by physicians that it causes neurocognitive disorder, diabetes, if you give such high dose.
There is no such data. Most of us are emotionally connected to these side effects, like we are connected for a long time to HDL. So this is like we were connected to antioxidant, vitamin E. It takes time for the community to understand that there is no such data. Like even in pediatric group, if you do LDL reduction, there is no psychosocial, physical, sexual retardation in growth. All pediatrician feels that statins or the lipid lowering can't be given to pediatric age group because it will retard their sexual growth. There is no such data. So Dr. Aziz, I am very clear about it. There is no data which is talking about these kind of side effects. The neurocognitive effects are related to high dose statin. They are not related to ultra low level of LDL. There is a disconnect between the two things. So when you use high dose statin, they are neurocognitive disorder. But when you achieve ultra low level of LDL by combinations, by newer agents, there is no such problem. No hemorrhaging, no cancer, no cataract. There is no such data. It is an emotional connect. A very difficult question. The government guidelines at the moment in their programs is screening at 30. So less than 30, there is no data, no support, but you understand the lipid is a cumulative phenomenon. I talked about plaque years, like we talked about cigarette pack years. So conceptually, earlier you hit, better you are. Strong family history, high LDL, obesity, metabolic syndrome, smoking, stress. These are some of the factors if you find in a younger adult, probably they need to work upon. And it is very difficult for family to understand that at this 20 years of age, you need to start lipid lowering therapy because they are apparently healthy. So it's a paradox, but the science is earlier you start, the patient starts recommending at 8 to 10 years.
Dr. Rajeev.
That is not a possibility. That is not a possibility. The another possibility is that the disconnect at the moment in science is you have high LDL, but no atherosclerosis, because we are talking of probability, not certainty. There are many patients who have high LDL, no atherosclerosis. So one way forward is if you have high LDL and high coronary calcium, that means your LDL is expressing into disease, and these patients are more prone for events. But there are caveats, younger age, diabetes, smoker, family history, where the coronary artery calcium and LDL may not go hand in hand. In CRISPR therapies, they give a nomenclature of knockout of the gene, Verve technology. But in reality, PCSK9 is reduced by 50%. They are not 100% because there is PCSK7 also. So there are multiple pathways. When you use these CRISPR technologies, they are not knockout LDL. Their LDL doesn't come to zero. So these therapies are going to work in patients who are refractory to standard treatment rather than stand alone. And they are not knockout therapies as expressed in literature. Their LDL reduction is 50-60%. Dr. Amrish, yes.
Yeah,
I'm not
Dr.
able to hear.
Dr. Rajeev, you actually highlighted very, very clearly that if you have a very low level LDL, you can actually regress atherosclerosis.
Yes, sir. Please go ahead. I'm not able to hear you.
Sorry about it. There's some system issue. So you
Yes.
highlight very clearly that if you lower the cholesterol, you can regress atherosclerosis. This presumes that there is atherosclerosis to start with. What about the people? What level of LDL cholesterol would you recommend somebody who we presume there is no atherosclerosis to start with? For example, just started diabetic and his coronary arteries with a calcium score of 0, hypothetical, and there is no atherosclerosis. So what level of LDL will prevent development of atherosclerosis? We are not talking about regression. We are talking about preventing atherosclerosis from starting.
Yeah, there is enough data to comprehend, like Brown and Goldstein talked about 25. We have umbilical cord blood LDL is 25-30. Longer you maintain it is, better you are. But it is very difficult at the moment. Like HbA1c, the cutoff is 6.3, but the atherosclerosis starts at 4.9. So these are epidemiological cutoffs. We do not know them. We create artificial cutoffs depending upon the literature and understanding. At the moment, South Asians, the cutoff is 100 at the moment. But to my mind, we have to chase an umbilical blood level of LDL, which is around 25-30. How you maintain it is difficult. Should we medicalize everyone? I do not know. But the issue is, higher LDL you have, more probability of atherosclerosis there, and it is a multi-system disease. It is not confined to coronary atherosclerosis alone. So I'll say ideally 25-30 is the LDL we should live with. This is not a reality.
Sir, I just wanted to ask that there is a dose-dependent increase in glucose level. So when we are dealing with a person suffering from pre-diabetes or early diabetes, will it be good enough to give very high doses of statins?
This is another issue which need to be explored. This is not diabetes. It is called new onset hyperglycemia. This is not diabetes. Diabetes is a different, well-defined syndrome. So first thing is a new onset hyperglycemia. This is related to only statin. This is not related to ezetimibe, bempedoic acid, PCSK9, inclisiran. There is no, in fact, these drugs are favorable on glucose profile. So when you combine these drugs, it doesn't matter. Looking at the absoluteness of the new onset hyperglycemia, the first data came from Jupiter. And Jupiter showed that there is a new onset hyperglycemia. There are two ways to look at it. Number one, the absolute increase in HbA1c was 0.1%, which is almost negligible. Number one. Number two, it happened only in patients who had metabolic syndrome. If you are not obese, metabolic syndrome, you are unlikely to have worsening. Number three, it is related to statin dosage, not related to LDL lowering. So there is a guy who is on 40 milligram statin. He is likely to have it. There is a guy on 20 milligram and achieved an LDL of 50. He is not likely to have it. So there is a disconnect between new onset hyperglycemia and LDL. There is no correlation. The correlation exists with higher dosage of statins. And now with combination therapy coming up, high dose statin has become a step 2. Now we have started with combination. Like my standard prescription today is rosuvastatin 20 milligram and ezetimibe. It doesn't work to my satisfaction. Then I bring in bempedoic acid. Even if it doesn't work, then I increase the statin. That is how we go, because the most of the side effects which we are brought up and worried about are statin related, not LDL related.
Sorry, can I have a quick question? Sorry, doctor. I'm Sudhir Rathore from UK. Just a very brief. I know you are running late. Dr. Agrawal, thank you. Fantastic talk, as usual, if you can hear me. So I would like to ask, how often do you use cardiac CT or calcium score for primary prevention in intermediate risk patients? And what are your views about
We
it?
use it very frequent. We use it very frequently, and there are caveats. The calcium score is not 100% certainty. A zero doesn't mean zero. Zero means very low probability. So after 45 years of age, if you are intermediate risk, you have to do a coronary calcium score. In India, it is cheap. We do it left and right. In fact, there is a paper from Mayo Clinic just very recently talked about vasogenic erectile dysfunction. The further classification depends on calcium score. So once you come across a patient of vasogenic, vasculogenic, erectile dysfunction, the next way forward is calcium score. In fact, the paper, probably Dr. Khurram Nasir was also one of the authors. He talked about, like, we talk of female specific premature menopause, gestational diabetes, eclampsia as female specific risk factor. Similarly, he thought of talking erectile dysfunction should be brought in as a risk enhancer in intermediate. So calcium score is a good thing. If it is positive, you have some way. If it is negative in an appropriate patient, it classifies you to a very low risk patient.
Yes, sir. Good morning. Good morning, everybody. Dr. Nabar, please start your deliberation. The podium is yours.
Thank you very much, Dr. Ansari. Am I audible?
Yeah, you are
Yes.
audible.
Yeah, I'll try to share the screen.
Audible, well, and go ahead. Yeah.
Are the slides visible? The slides are visible, right? Hello. Am I audible and my slides?
No,
My
your
sister-
screen
Your
is
slides
visible.
are not
Your
visible.
screen is
Screen
visible.
is visible, slides are not visible.
Oh, slides are not visible.
No.
Share the presentation, please. Window, right window.
Somebody else has to stop sharing, I guess. Is that good? Are the slides visible?
Yes, you are visible.
Slides are visible?
Yes, you are.
The slides are also visible, right?
Slides are visible now.
Slides are visible. Yeah, just if somebody can say if I'm audible and my slides are visible.
You are audible, your slides are visible.
Okay, perfect. Thank you so much. Sure. I do not know if I can match the passion of Dr. Agarwal. In fact, I enjoyed listening to the talk and understanding more about lipids. Surely it was a great start to this session by Dr. Manoria, and I always can't thank him enough for inviting me to this his meetings, because they are always full of news topics, and while you talk it out, but you also find it interesting to sit through those seminars. So thanks very much, Dr. Manoria. And I'm going to concentrate on ventricular arrhythmias, some current concepts. And I decided to put forward the following 4 things that I wanted to concentrate on. One is trying to give a more understanding of sudden cardiac death and emphasizing the role of ventricular arrhythmia. Discuss how the role of MRI is increasing in evaluation of ventricular tachyarrhythmias, how to deal with VT storm, which is a medical emergency. And finally, there is a silver lining that some of these idiopathic ventricular tachycardias can be looked at differently. So let's start with sudden cardiac death. I think the key words here are that it's a natural death. It occurs unexpectedly, and the demise happens within 1 hour of the onset of the symptoms. Even the prodromal symptoms have started not more than 24 hours ago, and usually cardiac arrest is a terminal event. And sometimes, due to the efforts of the community or in the ICU, you may be able to get the return of spontaneous circulation, and that the patient may die after a day or 2, but still it is sudden cardiac death, and therefore we should record it as such, even though the biological death is kind of delayed. One thing that is less understood when dealing about sudden cardiac death is syncope is also a possibility that the syncope could have been an aborted sudden cardiac death. And it is many times taken lightly by the physicians and the cardiologists alike, not given its due investigational need as, say, for example, dyspnea or angina. So syncope is typically very rapid. There is loss of postural tone, and there is luckily a prompt recovery if it happened to be because of a ventricular arrhythmia. So syncope should be investigated, particularly when you have a patient with a known structural heart disease. Now, sudden cardiac arrest is very clearly due to a ventricular arrhythmia of some form. If you look at this pie diagram, you can see that except 15% of the time, so largely that is more than 85% of the time, some form of ventricular arrhythmia, either VT, VF or torsades is responsible for sudden cardiac arrest. And although the sustained monomorphic VT, you may not always have to shock. There are other ways to terminate a VT, but in case of a VF, you would always need a defibrillation. In ventricular tachycardia, what is usually done is cardioversion. So one has to kind of understand importantly that sudden cardiac arrest means a ventricular arrhythmia almost all the times. It is true at the same time that the cause of sudden cardiac death can often be an acute coronary syndrome. As you can see here, this patient has an acute inferior wall MI, clearly ST elevations in the inferior leads. And then what you have is an polymorphic VT. So primary VF can be responsible for sudden cardiac death, and that remains, acute coronary syndrome does remain one of the common cause. If you look at it age-wise, yes, coronary artery disease is the most common cause of sudden cardiac death, and this age continues to come down, and therefore some importance to what Dr. Agrawala discussed so vibrantly. But when you look at younger people, it is cardiomyopathies or channelopathies that might be responsible. So there is a little difference in the etiology of sudden cardiac arrest in people less than 40 and more than 40, broadly speaking. Now, this is one more myth that people who have structural heart disease have a heart failure and so-called stable, that is NYHA class 2, they are deemed to be stable and not much beyond that is done in the follow-up. That's true. With the availability of SGLT2 and ARNIs, we have treated them very well and also reduced the risk of sudden cardiac death. But if you look at this pie diagram, you can see that almost 2/3 of the time, your so-called stable heart failure patient will have a sudden cardiac death. As the heart failure worsens, it is mainly the progression of the heart failure that causes it. So your so-called stable heart failure patient is actually at more risk of a sudden cardiac death, something that is probably not appreciated so widely. So the question is, can you predict these ventricular arrhythmias? Can you risk stratify accurately for sudden cardiac death? Truly speaking, we have limited abilities, and therefore you have to take a good judgment call. And how do you do that? Look at the ECG carefully. So for example, when the ECG shows a wide QRS with some kind of a bundle branch block or IVCD kind of a pattern, reduced voltages, these ECG signs are not good. These patients have a bad LV function, a scarred ventricle, and therefore they are at a risk of sudden cardiac death. Here is one example. You can see that it has a RBBB-like morphology with the left axis, a wide QRS, a fractionated QRS. A fractionated QRS is bad news in terms of risk of sudden cardiac death. The other thing that you will usually follow up is by doing an echo. As the ejection fraction, you can see here, as the ejection fraction worsens, the risk of sudden cardiac death increases. And therefore, in most primary prevention trials to prevent sudden cardiac death, 40% is accepted as some kind of a gospel ejection fraction. But if you look at this diagram, you can see that the risk of sudden cardiac death is continuous, and it is just that it increases as the LV ejection fraction worsens. One more thing, and nowadays we have many tools available to do arrhythmia monitoring. If you see a non-sustained VT on either a Holter monitor, or you have nowadays loop recorders, or sometimes or rarely you may do an implantable loop recorder. So if you see these kind of non-sustained VTs or a high PVC burden in patients who have a structural heart disease, then it implies there is a sudden cardiac death risk. Coming to this thing that is expect the unexpected. So for example, it is not always that you can risk stratify better, but worse is if you have a death due to VT-VF in an ICU, then that is certainly a bad news or would reflect badly. What do I mean by that? Here is a patient with multiple comorbidities, myelodysplastic syndrome, admitted with fever on multiple drugs, as you can see here. And what you found one day on the rounds on the ECG is a prolonged QT. Now you have to monitor these ECGs and the monitors carefully to see if there is a, because they could be at the risk of a polymorphic VT and a sudden cardiac death. So multi-polypharmacy is one of the reasons, but there are other background characteristics which help you to pick up the unexpected or be careful about the unexpected is females coexisting bradycardia, polypharmacy, concomitant drugs and electrolyte disturbances. All this melange can act to increase the risk of polymorphic VT and sudden cardiac death. As you can see on this rhythm monitor, the QT is prolonged. If you didn't pick up this prolonged QT, one day you get a R-on-T, a torsades later, degenerating into a VF, and unless you shock him out, being vigilant for that, you would lose the patient. So you can risk stratify sudden cardiac death in structural heart disease to some extent, but you only have to be vigilant when you're dealing with such a sick patient in the ICU, because torsades is something that will come unannounced, but your prolonged QT would help you to discuss that. Worst thing that you could do is use Cordron in patients who have polymorphic VT, because it only prolongs the QT further and risks the sudden, there is the polymorphic VT more. So what is important to understand that a monomorphic VT is like this, where there is a bit to bit same kind of QRS morphology, and polymorphic VT is different, where you have a change in bit to bit morphology. Why do you need to understand differently is because their etiology is different. For example, a monomorphic VT is related to a scar and a number of etiologies which result a scar in the heart. And polymorphic VT, the causes are different, drug-induced versus the channelopathies, a number of these. So these are both treated separately. So you have to get an understanding of what is the ECG showing, what kind of VT it is, and therefore from there the treatment differs. Let us switch gears here to the second point, increasing role of cardiac MRI in working through a patient who has a VT. So there are a number of things that are diagnosed looking at the MRI more than what the echo can tell you. A delayed enhancement tells you about the scar. There is a T1 mapping which tells you about fibrosis, and T2 mapping which tells you about the edema. These are a number of things that can be done today when one orders a cardiac MRI, and it is been increasingly used in the present day practice when you're dealing with structural heart disease. So here is an example of dilated cardiomyopathy, where you may find a mid-myocardial scarring. Many times you don't find that. There could be a difference in the VT risk probably based on that. Here is a patient who has a granulomatous cardiomyopathy, and if you look at some of these pictures, you can see that there is a scarring within the mid-myocardium. So scarring, or if you look here, there's scarring here, there's scarring here. So scar burden is important to evaluate when you are discussing the VT risk. Here is a patient who has hypertrophic cardiomyopathy. You have standard left ventricular wall thickness, which you can assess better than when you're doing an echo. And the more the thickness, you know, more the risk. But what more you can evaluate by doing an MRI is evaluate this scarring pattern. As the scarring increases, the person with 36% scar is more at a risk for sudden cardiac death than a HCM patient with a 9% scar. So the scar burden is an important evaluation that you do in patients by using an MRI, something you may not be able to do well using an echo. Here is another structural heart disease, arrhythmogenic right ventricular cardiomyopathy. You can see that the RV is dilated. There are crenations. There is a hypokinesia of the free wall, and you can pick that far better on an MRI. So therefore, MRI is very useful in the present day. Is used more and more. Unfortunately, there is a limited availability to do an MRI. The skills are limited, but these are important. This is an important and very important investigation today when you risk stratify for structural heart disease. The third thing that I want to discuss with you is VT storm. Now, clustering of VT episodes, when number of VT episodes happen within 24 hours, that is worse than when you have episodes which happen over 90 days, say. So clustering of VT episodes is bad news. When they happen frequently one after the another, it is a bad news. What is a VT storm? This clustering of VT episodes is a VT storm. And by definition, if you have, say, 3 episodes within 24 hours, or an VT which is incessant for 12 hours, or you have 3 appropriate AICD shock in 3 hours, then that is a VT storm. And this clustering in a short time is considered as a bad news because it has a high mortality risk. One needs to increase the treatment level. You need to transfer this patient to a tertiary care where a multidisciplinary approach would be required to take care of VT storm. You would need a good ICU care. You would need an electrophysiologist to program the ICD better. You would need a good internist to identify the reversible causes. You might need an anesthetist to do a good intubation, ventilation, and at times you would also need to go ahead and do ablation or sympathectomy, all of which require a sympathectomy can obviously require a surgical hand. And so therefore it's a team approach and not necessarily easily and successfully managed in small setups. The moment you have a VT storm, it is important to shift this patient into the ICU. It's a teamwork there. Number of reversible aspects like ischemia and electrolyte disturbances and decompensated heart failure commonly need to be taken care of. But thereafter, you have to discuss how you are going to up-titrate the antiarrhythmic drugs, how you may need to sedate and ventilate the patient to autonomic modulation, and then you have to program the ICD if there are recurrent shocks, and eventually you might need to ablate such a VT to some effect. So therefore, these patients need to be dealt at higher centers. Now, what do you mean by escalation of drug therapy? Now, beta blockers, amiodarone will go in IV. And when this combination is not yielding the result, when you still have refractory VT storm, you will have to add mexiletine, add lignocaine, which can be later converted to oral mexiletine. So you have in your hands on amiodarone, beta blocker, and mexiletine, which will need to be up-titrated. Unfortunately, we do not have procainamide in our setup, but up-titration of medical therapy for us would mean beta blockers, amiodarone, mexiletine, intravenous to start with, or eventually coming to oral when the storm settles. What is programming the ICD? Now, inappropriate shocks because of atrial fibrillation, of course, you need to treat atrial fibrillation. Many times there are shocks for VT, and it is not essential that every time there is a VT, the device should shock. So therefore, you can reprogram the device better. When you read the ICD and you find that there is a non-sustained VT that is getting shocked, you can reprogram the device. When you have slow VTs that is getting shocked, you can program more pacing therapies. When you see that the fast VT is treated at VF, you can add pacing therapies. When you see that the ATP is accelerating to VT, VF, you can reduce the ATPs and add shocks. So there are a number of these things that an electrophysiologist is well trained to do and handle the ICD when recurrent shocks is a problem. So therefore, I call it a team approach. This is something that your intensivist and anesthetist can do better. So this is again less appreciated. Anesthetic agent is probably the best antiarrhythmic. Why? Because it cuts off the sympathetic tone significantly and removes that trigger. So sedation plus mechanical ventilation, sedation usually using midazolam, fentanyl, or propofol, and then ventilating the patient has a great chance of reducing the VT storm, has a great chance of reducing the VT episode. So that is your next mantra after escalating the antiarrhythmic drugs therapy. And then you have neuroaxial modulation. So when your shocks happen to be repeated or VT episodes happen to be repeated after your sedation and ventilation, then the next thing that you can do is couple of these things. You have what is stellate ganglion block, which your pain specialist can do under ultrasound guidance or anesthetist can do. You can do a transthoracic epidural anesthesia by inserting an epidural catheter. And when things are still bad, you can do a bilateral cervical sympathetic denervation by a VATS procedure. So there are a number of these things which will cut down the sympathetic flow to the heart and reduce the chance of reducing the VT storm or controlling the VT storm. So what is done in the VATS procedure by the surgeon is bilateral sympathectomy. So from the T4, all these T4 ganglion and the cervical sympathetic ganglion is excised or fulgurated using a cautery probe. And this is the way you do a bilateral cardiac sympathetic denervation. And sometimes when the substrate seems to be the cause for causing VT, then there is a VT ablation. So if the VT is slow, then you can target that particular VT by precisely finding out. So this is a three-dimensional electroanatomical map where you see the scar, you have a border zone, and then you have a healthy myocardium. So this border zone is where the VT circuits are there, and then you can target these regions and take care of one VT if that is the recurring VT particularly. This is the VT circuit, so you can target one VT or If it's an unmappable or very fast VT where you cannot let the VT go on and you cannot map during the VT, then you do what is called a substrate modification in these border zone areas and thereby kind of kill those areas which are responsible for the VT circuit. The last thing that I want to bring home is there is a silver lining to this VT business. There is something called as idiopathic PVCs or VT, and we must recognize them differently than VT in the presence of a structural heart disease. So for example, some time back, we wrote this chapter in Tandon's textbook of cardiology, where there are a number of idiopathic VTs, and all these VTs from the right ventricle and left ventricle are actually not a SCD risk. But I will discuss only two forms of most frequent idiopathic VTs with you. One is these forms of PVCs, typically a left bundle branch type with tall R in 2, 3 and AVF. These are the PVCs which come from the outflow tract, most commonly the right ventricular outflow tract, sometimes even from the left ventricular outflow tract. And depending on their frequency, they can bring along with a possibility of symptoms and causing what is called as tachycardiomyopathy or resulting in a drop in LV function. The another idiopathic VT is the typical fascicular VT, which is a relatively not so broad or relatively narrow QRS right bundle branch block pattern with a northwest or a left axis. And this VT in structurally normal hearts is again an idiopathic VT. Now, both these forms do not entail a risk of sudden cardiac death, and therefore you have to deal with them differently. How do you deal with the PVCs differently? It depends on, basically forget this complex chart, look at three things. Symptoms, if the patient symptomatic, is the PVC burden more than 10 or 20%? Are the PVCs harming the LV ejection fraction, causing the LV systolic dysfunction? In which case, once again, that is summarized here, in which case you need to ablate them and suppress them, because drug therapy may not be that good to suppress these PVCs from the outflow tract. So here is an example of ablation, outflow tract PVC, tall R in 2, 3 AVF, left bundle branch block pattern. This was excellently ablated from the RV outflow tract septal surface. Immediately after initiation of energy, you can see that the PVCs, which were in a bigemini form, have vanished. So therefore, that is a successful ablation. So, so some of these idiopathic PVCs, particularly the outflow tract and the fascicular VT or the idiopathic LV tachycardia, are some of the most the two of the most common idiopathic ventricular arrhythmias, which are not associated with the risk of sudden cardiac death and can be very well ablated curatively. So, ladies and gentlemen, if I have to conclude, there are once again 4 points which are in line with my agenda. One is sudden cardiac death. At public level, we should initiate CPR training in our surroundings, and therefore that is going to make a big change in how we react to somebody who has a syncope in front of you in the public place. If there are a lot of bystanders who are trained in a CPR, and if we have increasing access to what is called as public access defibrillators. So if you have those defibrillators like the one that you see in airport and many more places, then maybe will make some difference, because the chance of survival in a SCD patient is decreasing by 10% every minute. So you have those initial 10 minutes to react. At the physician level, is when somebody has a structural heart disease with a significant LV systolic dysfunction or has a syncope, we must look at it carefully. Second thing is MRI. There is a limited access. There is a difficulty in the skill of reporting at different places, but MRI is going to be the next future in terms of risk stratification for VT. VT storm, when somebody has a cluster of VTs, that is different. We need a team approach to that. This patient should be moved at a tertiary care. What is underappreciated is the role of suppressing the sympathetic tone by intubation, ventilation, first step, transverse epidural anesthesia, second step, and otherwise a bilateral cardiac sympathetic denervation as a surgical procedure. So this is all very specialized. Programming the ICD is something that is specialized. Therefore, it needs to be done at tertiary care. And the silver lining is that whenever you have idiopathic PVCs and VT, don't mistake them as a risk of sudden cardiac death. They can be ablated curatively. So I think there are always many things that can be discussed, but I think in the given time, I decided to focus on these aspects which are more contemporary and probably a little less appreciated in the clinical practice. So I think I'll thank you here, and I think it's been wonderful always to come online for this meeting. Thank you very much.
Dr. Ashish, beautiful. lovely and give the pearls for the physician and cardiologist. Can I have one question to you, sir?
Sure, please.
Which VT will not treat?
See, it is like this. If you have a VT in a structural heart disease, even if it is hemodynamically stable or unstable, they need to get an ICD. So very clear. There are these idiopathic VTs, very classical sites of origin. In absence of structural heart disease, not a risk of sudden cardiac death, they can be ablated. The discussion comes when you have those PVCs, and that is what most of us face in our practice. You have a patient who undergoes a LIC underwriting or has a pre-employment checkup or an intra-employment checkup, and they show up some PVCs, and then the discussion comes up. So basically, if somebody is asymptomatic, has structurally normal heart, you do his Holter or a stress test and find that those PVCs don't get into any more malignant forms. These are the patients whom you can reassure and not be aggressive about them. Sure.
You did discuss about class 1A and B. So 1C is not to be given in VT.
That's right. So whenever you have a patient with structural heart disease, you can use beta blockers. That's class 2. You can use amiodarone, which is class 3. All of us know that. If the LV function is not bad, you may use sotalol orally. Nowadays, we have the availability to use class 1A, that is the mexiletine. But class 1C, flecainide and propafenone, which are available, are a strict no-no when you have structural heart disease with ventricular arrhythmias. All of you know that they came out of the CAST trial, although CAST trial had a very specific subset of patients post-MI, early post-MI PVC suppression was the substrate of that CAST trial. But since then, we have all developed a dislike for class 1C drugs when you're dealing with VT in structural heart disease. Sure, we will still hold on to that.
Yeah.
Thank you.
Dr. Ashish,
Thank you.
Yes, doctor.
Dr. Ashish, I have one question.
Sure.
The VT and cordron has become synonymous in every situation. It's
Anymore,
a
I think.
knee-jerk reaction with
Yes.
cardiologists like me and clinicians everywhere. So I want to know, like Maxitil being coming up and easily available, not coming up, it is easily available now. What are the subset of patients where you will say, Dr. Agrawala, go for Maxitil? Or it is always a friend after cordron? Where are class 1, let me say, step 1 indication of Maxitil in VT? That is my question.
So lignocaine, we all know from ages, was always advised in the acute MI setting, wrongly initially for every patient to start, and then for any for ventricular arrhythmias in the acute coronary syndrome setting, lignocaine was some kind of a choice drug. And this could be followed by mexiletine as an oral form of class 1A drug whenever you thought that the response to lignocaine was good. Coming to this class 1A series, it is never above amiodarone when you are using for sustained monomorphic VT in structural heart disease. So cordron does remain your go-to drug. And when you have more and more clusters of ventricular arrhythmias coming despite cordron and beta blocker, that's the time in the acute situation you would add lignocaine. And when the situation is under control, you would convert the IV cordron to oral cordron and IV lignocaine to a mexiletine. So that is where mexiletine, it should not be wrongly presumed that this is something above cordron in VT with structural heart disease. The other places where you can use are in drug-induced torsades, the point, or you can use it, of course, in acute coronary syndrome. Again, it is not necessarily above cordron, but it is fair enough to believe that if a ACS patient gets a polymorphic VT, you would use lignocaine. If it is fair enough to believe that if there is a drug-induced torsade, the points you would use lignocaine. So these are, and then convert it to, if required, mexiletine. So these are the places where the class 1A has a role. Not to misunderstand that as being superior or really an alternative to cordron. Yes, it's add on many times.
Thank you.
You have to know the level of activity before T2 does tell you about the activity, and T1 is more of fibrosis. But the alternative, usually you do dual imaging and you would ask for a FDG PET scan because that tells you also about the activity of the disease. And whenever you find some lymph nodes in the hilum or mediastinum, or more easily, if you have peripheral lymph nodes, then obviously it's easy to biopsy. If you have hilar or mediastinal lymphadenopathy, then you have the options of CT guided biopsy or EBUS guided biopsy or something like that to get a tissue diagnosis. So as far as possible, you should try to differentiate the two by a tissue diagnosis. Tuberculosis does remain more of our disease, and sarcoidosis till now was perceived not as our disease, but more and more we know that we also find a lot of sarcoidosis here. At the end of the day, you are still confused, and there is a terminology like sarcotuberculosis where people would give steroids only after starting AKT. So this can tread into the gray zone. If possible, you should achieve a tissue diagnosis. That's mainly by lymph nodes. Myocardial biopsy is something that is very difficult because you cannot sample the diseased sites. You have to sample only the safe sites, and therefore it is less used. And we do rely on the indirect evidence from FDG PET and lymph node biopsy as more direct evidence. Certainly uncommon. CPVT is something that is seen in structurally normal hearts. It is a kind of inherited arrhythmic disorder, and that is very easily diagnosed when you get a history of people having syncope or children having syncope when they are playing or something. And if you put if somebody to stress test and you see the polymorphic VT happening only during that exercise, this is typically a catecholinergic polymorphic VT, they have a normal QT interval. So that is what is CPVT is about. Bidirectional VT is more about toxicity. So many times the digitalis toxicity or some Ayurvedic drugs which have contaminants, and that kind of scenarios you see this bidirectional VT. It really rare to see that. It has a wide QRS because it originates in the myocardium and the two ventricles get activated one after another, and the cell-to-cell transition conduction of the impulse in a VT is through the myocardium. That is why it is broad QRS. But if the same VT comes from the septum, then the two ventricles would get activated kind of simultaneously, and therefore your QRS width would reduce. So that is what happens, say, following an anterior wall infarct or in sarcoidosis where you have septal involvement, you can have a narrow QRS VT. The thing is, whenever the VT originates close to the conduction system, that VT penetrates the conduction system retrogradely, and a major amount of myocardium may get activated antegradally through the conduction system branches. So that is the reason when a VT originates close to the conduction system, you can have a narrow QRS. And one of the example of that was that idiopathic fascicular VT that I showed you, which arises